actually started off in primary care. I was working for Mass General in one of their community health care centers. So I was doing community pediatrics and medicine, but I was also precepting med-peds residents in the MGH med-peds program. I found that I was really enjoying the inpatient side of things more than the outpatient side of things. So somewhere along the line, it just kind of clicked for me that that's what I should be doing. And coincidentally, at that same time was when hospital medicine was just starting to take off.
That I wanted to be a generalist. I always wanted to do everything. I never wanted to be organ-based only. And, certainly there are things like infectious disease that are appealing, but you get to do those when you're a hospitalist anyway. But I never wanted to be an outpatient doc. I was an outpatient doc, and I definitely gravitated toward the sicker patients. And I wanted to be able to sort of have that constantly changing, challenge of new patients and patients that were sicker. It's given me the ability to sort of to branch out and do all kinds of different things. I've gotten really into quality improvement, as many hospitalists are, and I don't think I would have ever done that, had I become a pulmonologist. And I think the experience in quality improvement has absolutely defined my career.
I know that there are a lot of people who are generalists at their core, but they still have a sort of a hobby-like interest in a subspecialty. And I think that's perfect for those types of individuals who like the variety but don't want to get totally locked in to a subspecialty like a subspecialist would. At UCSD, we have a liver hospitalist program. We are progressing towards establishing an oncology hospitalist program.
It would be early on, it can be challenging. You can think of it as challenging to be a hospitalist because you're not sure who you belong to, especially if you are thinking about a career in research. If you're interested in pulmonary research, you're not a pulmonologist. If you're interested in, emergency response, you're not an emergency medicine physician. But ultimately, in the end, it turns out to probably be more of an advantage than a disadvantage because I think it gives you a very different perspective.
And then from a research standpoint, there's a lot of opportunities in these some specialty hospitals because it's sort of a greenfield in regards to practice. There aren't a lot of liver hospitalists or oncology hospitalists, and so any data you collect is groundbreaking. And this has actually been an issue that has come up recently in that the Joint Council for Pediatric Hospital Medicine has moved forward with a petition to the American Board of Pediatrics to make pediatric hospital medicine into a ACGME certified subspecialty. What that means is that in the not too distant future, you will have to have essentially board certification to do pediatric hospital medicine. My advice to med-peds trained individuals like myself is if there is any inkling that you might do inpatient pediatric hospital medicine, you should think about a fellowship in pediatric hospital medicine because not having that under your belt would really limit what you can do in pediatrics. Having been someone who has thought about fellowship in the past of various sorts, it's once you get older and you have a mortgage and kids, it's really hard to go back and do fellowship. So.